Sadda, so nice to see you at ASRS. Hope you're enjoying the meeting.
Very much, Sagar. Really good to be here with you.
What are the highlights of this year's ASRS meeting for you?
Well, I think that obviously there's always, every year there's great content, lots of talks, very rapid fire, so you can get overwhelmed with all the information. But I think one of the real highlights actually is the fact that we're in Stockholm. It's nice that the meeting moves internationally. So one of the big highlights is there are a lot of people that often don't see at ASRS that are actually at this meeting because of the fact that it's an international location, obviously a beautiful location, Stockholm. So a big part of the meeting is not only just the scientific content, but also the ability to interact with colleagues and form new collaborations and discuss ideas and experiences. So that part's been great.
Thank you. Dr. Sadda, would you mind giving us a brief summary on your recent work regarding blue light versus green light autofluorescence for geographic atrophy?
Yeah, so absolutely. So, being able to evaluate patients' geographic atrophy has really come to the forefront because there are at least a couple of approved therapeutics that are available that have been cleared by the FDA. Mm-hmm. So there's been a focus on finding patients or being able to monitor them. And the reality is that for those who've had their eyes imaged with blue autofluorescence, it can be uncomfortable. And some people even wonder, is there any long-term toxicity, things of that sort. But separate to that, the big issue, I think, is the availability. And so one thing we know about geographic atrophy is that many of these patients aren't in retina practices right now. That many of them may be in optometric or primary eye care provider offices and practices, ophthalmologist offices. And so the question is, how can those individuals participate in finding these patients, maybe even identifying patients for trials, for example? And they often don't have blue light autofluorescence in their offices, but many people commonly have green light autofluorescence, especially, for example, on Optos's platform. So that's very common in primary eye care provider settings. And so the question we want to ask is, can we actually reliably assess atrophy? There have been some prior studies that have compared green and blue for assessing atrophy, but that's been on a small field image. But can you do it on an ultra wide field image, which is not an averaged image, it's a single capture? Is the quality sufficient? Is the resolution sufficient to actually identify the atrophy and then measure it reliably? And so that's the study we did. So every patient with atrophy, they had both an Optomap with green autofluorescence imaging, as well as spectralis blue light autofluorescence imaging. And then we had mass graders measure them a couple of different ways using Regions Finder software as well as just manual segmentation. And what we observed was that it could be done repeatedly. So if you had independent mass graders do it, they can get repeatable measurements. Although I will say there were some differences in the absolute values. So the other thing we found is you can't just use them interchangeably. So you can use, for example, green light autofluorescence with the Optos platform in a trial, but you'd have to use the same instrument for that patient throughout, because there are some differences which get to how you deal with wide field imaging. Because one thing with Optos is they figured out how to actually do the measurements reliably by taking a 3D image and essentially being able to warp it properly onto a 2D sort of image plane.
Thank you so much, Dr. Sadda. Enjoy the rest of the meeting.
Okay, thank you.
Take care.
clinicianlink.ai